Hello everyone, a very warm welcome to everyone in the part 4 video of the thyroid carcinoma. Here we go through two things. First is poorly differentiated and anaplastic thyroid carcinoma. Next we go through the medullary thyroid carcinoma, various pathogenesis, clinical features and morphology, both gross and microscopic features. First, we go through the introduction of the anaplastic thyroid carcinoma that present with aggressive neoplasms of the thyroid follicular epithelium, and this accounts for high mortality rate amongst the all thyroid carcinoma. And the peak incidence is at 65 years of age, and approximately one-fourth cases of anaplastic thyroid carcinoma previously present with a history of well-differentiated follicular neoplasm, which later on becomes so malignant that it becomes poorly differentiated. And morphology, we see there is it composed of cells with minimal follicular differentiation, so it is named as poorly differentiated anaplastic thyroid carcinoma. And insular growth patterns appears where the tumor cells form tight clusters or island that resemble small islands and separated by loose stroma or blood vessels, and intratumoral necrosis along with the frequent mitosis can be appreciated. Similarly, the various morphology can be seen in anaplastic thyroid carcinoma, like large pleomorphic giant cells could be like osteoclast, like multinuclear giant cells, and in other cases we can see spindle cells with sarcomatous appearance, and sometimes we can see mixed spindle and giant cells, and also we can see neoplastic cells express the epithelial markers like the cytokeratin, and these are negative for thyroid differentiation marker like thyroglobulin. And various clinical features that are associated with anaplastic thyroid carcinomas are there we can see the rapidly enlarging bulky neck mass, and these masses will compress and invade the adjacent structure, which results in the occurrence of the symptoms like dyspnea, dysphagia, hoarseness, and cough, and death may occur in less than 1 year. And treatment could be radical surgery, external beam radiotherapy, radioactive iodine immunotherapy using immune checkpoint inhibitors. Next, we see the medullary thyroid carcinoma, which is associated with MEN2A and MEN2B. So this is also called as a neuroendocrine neoplasm that is derived from the parafollicular cells or C cells of the parathyroid gland. And this may present as both familial and sporadic variants, and they both show the activating point mutation in the RET proto-oncogene. And other we can see 70% of this medullary thyroid carcinoma occurs sporadically, and the rest associated with MEN2A or MEN2B syndromes, and those which are associated with MEN2A or MEN2B syndromes that occurs in younger patient even in the first decade of the life, and sporadic or familial both occur in adulthood. Yes. And the peak incidence is in the 40s and 50s. Though the 30% of the medullary thyroid carcinoma is associated with MEN2A or MEN2B syndromes, but those which are sporadical or familial variant that may appear in adulthood most commonly, and peak incidence in the 40s and 50s. And like the normal C cell, parafollicular cells, these tumor cell also secretes calcitonin. And morphology. First, we go through the gross morphology of medullary carcinoma. First, sporadic medullary thyroid carcinoma present with as solitary nodules, while familial one show bilaterality and multicentricity, and texture is faint pale gray to tan and infiltrative, and foci of hemorrhage and necrosis can be seen in the larger lesions, and that may extend through the capsule of the thyroid. That means capsular invasion can also be seen there. And here we can see that retraction of artifact, these are the important. Next of the tumor cells, that means tumor cells are present, and these tumor cells are round, polygonal, or spindle shaped, and these tumor cells are arranged in nest or larger eyes island, and that exhibit salt and pepper chromatin like appearance. Its nuclei has salt and pepper like chromatin, and extracellular pinkish amyloid materials can also be appreciated here. You can see these are the amyloid amyloid deposition, and this shell, which are round, polygonal, or spindle shape. Such cell may form solid nest seeds, and the follicular formation and the colloid are absent in such cellular arrangement. That means you can see there we rarely see any colloid in between the follicles, but that means even the follicle as well as colloid both are absent in such cellular arrangement which are present in medullary thyroid carcinoma, and the nuclei are round or ovoid and coarse granular salt pepper like chromatin pattern, and the nucleoli are very inconspicuous. Cytoplasm is granular and maybe eosinophilic or basophilic, and cellular variability is present. That means they show some degree of pleomorphism with larger bizarre nuclei or binucleated cells sometimes occur. And the extramal and extracellular features that we can appreciate in medullary thyroid carcinomas are like there is amyloid deposition that we saw in the figure earlier, and this amyloid is composed of the altered calcitonin in molecules that is produced by the tumor cells, and that is amorphous with eosinophilic extracellular materials, and this is stained by the Congo red stain, and that will exhibit the apple green birefringence under the polarized light microscopy, and microcalcification can also appear within the tumor cell clusters, which is dystrophic type. That means dead cells are present within that, and that is in association with amyloid rich areas. And high grade features can also be seen, like there is a high ki67 proliferation index. That means that also include the tumor necrosis and hemorrhage with increased mitotic activity. This ki67 protein is found in the cells during the active phases of the cell cycles, like S phase, G1 phase, G2 phase mitosis, but not in resting cells or the cell which are in quiescent phase. In such cells, Ki67 protein are not visible. And this Ki67 proliferation index measures the percentage of the aggressiveness as well as a growth rate of the tumor cells. And if any tumor cell present with a high Ki67 proliferation index, that means that is more aggressive and has worse prognosis. And the characteristics feature of familial medullary thyroid carcinomas are that present with multicentricity. That means that arise from multiple sites within the thyroid gland rather than a single origin. And they are well demarcated but not encapsulated. And the sharply outlined but not have a surrounding fibrous capsule, and the location that is mostly present in the upper thyroid of the thyroid lobes where the highest concentration of the parafollicular cells is located. And differentiating familial from sporadic medullary thyroid carcinoma features are essential to see to differentiate these familial and sporadic one. Sporadic are unilateral. About 75% of these medullary thyroid carcinoma cases are sporadic, and that as a single or unilateral tumor. But in familial, bilaterality and multicentricity are seen, and these are the inherited forms of the multi medullary thyroid carcinoma. And there is a predominant bilateral and multicentric. That means bilateral means both lobes of thyroid gland is affected. And the clinical features of medullary thyroid carcinoma are that is sporadic cases may present in um, may present with masses in the neck, and these masses may lead to compression and invasion to the adjacent structures, and that may be associated with dysphagia or sleep. And paraneoplastic syndromes can be seen in sporadic cases due to the secretion of the peptide hormone, like diarrhea due to secretion of the vasoactive intestinal peptide, and Cushing syndrome due to the adrenocorticotropin hormone secretion. Despite the raised calcitonin, hypocalcemia is not appreciated in this medullary thyroid carcinoma, although there is raised calcitonin. And two things that is secreted by the neoplastic cells can be useful as biomarker. One is a circulating calcitonin and carcinoembryonic antigen. In case where calcitonin negative cases are present, in those cases, carcinoembryonic antigen can be seen or can be monitored to diagnose this medullary thyroid carcinoma. That means carcinoembryonic antigen is useful in those cases where calcitonin negative tumors are present, and this is essential for pre-surgical assessment of the tumor load. And the familial medullary thyroid carcinoma present with various clinical features as these symptoms may be localized to thyroid gland, and that is arised in context to multiple endocrine neoplasm to be carrying the germline mutation, RET mutation, and for this thyroidectomy is the primary treatment, and metastasize more frequently than those with sporadic and main. And there is the presence of C-cell hyperplasia or micromedullary carcinomas. And several small molecule inhibitors of RET tyrosine kinase for patients with medullary carcinomas can be useful for its treatment. And it carries germline mutation in the RET gene, so RET tyrosine